A review from arterial blood gas shows that the normal pH value in our blood is between 7.35 and 7.45. Less than 7.35 will contribute to or will be an acidosis, where greater than 7.45 is an alkalosis or an alkalotic blood sample. The PaCO2, which represents the respiratory system, is normal value of 35 to 45 torr. Less than 35 would be an alkalotic. Greater than 45 would be an acidosis. PaCO2, when it mixes with water, turns into carbonic acid. So therefore, we can say that PaCO2 acts as the acid in our body, whereas bicarbonate, which normal value is 22 to 26, the metabolic system, less than 22 of the bicarbonate level would be an acidosis. Greater than 26 would be an alkalosis. And then from our arterial blood gas, we can also get our oxygenation level. A PaO2 of 80 to 100 torr is normal, 60 to 79 mild, 40 to 59 moderate, and less than 40 is something we can say is a severe hypoxemia. So when we're looking at an arterial blood gas, first look at the pH and determine if the sample is acidotic or alkalotic. Then look at your PaCO2 and bicarb and do the same thing. Then determine if there's any compensation by the non-primary disturbance, and then determine if your sample is either fully or partially compensated by looking if the pH is within normal limits or if it's not. So a respiratory acidosis will show a pH of less than 7.35, a PaCO2 greater than 45, and a bicarbonate level within normal limits. It'll be compensated, fully compensated, if the pH is within normal limits and the bicarb is greater than 26. We can also call this a chronic respiratory acidosis, where there's only partial compensation if the bicarbonate level is greater than 26. If there is no compensation, we can say that this is an acute blood sample. And it usually takes about 24 to 48 hours for metabolic compensation. So your patient will generally present with the acute respiratory acidosis. Respiratory alkalosis happens with a pH of 7.45 or greater, PaCO2 less than 35, bicarbonate within normal limits. There will be metabolic compensation if the bicarbonate level is less than 22, and then the pH is within normal limits. And if it's only partially compensated if the bicarbonate is less than 22 and that pH is not within normal limits. A metabolic acidosis happens when there is a pH of less than 7.35, the PaCO2 is within normal limits, and the bicarb is less than 22. We will have respiratory compensation if the pH is within normal limits and the PaCO2 goes down lower than 35. Only partial compensation if the CO2 goes down to less than 35 and the pH is not within normal limits. The most common etiology or cause of metabolic acidosis is renal failure. Now, we are going to elaborate a bit on metabolic acidosis. Fixed acids in the body can be lactic acidosis, ketone acids, uric or phosphoric acids. These acids are all released during cellular metabolism. And we know that during cellular metabolism, if our body is going to maintain homeostasis, we have to have a good oxygenated environment in those tissues. So when we don't and homeostasis is disrupted, we could build up these fixed acids, leading to a metabolic acidosis. Well, one of the ways we can see if these fixed acids are being increased in our body, and it really helps determine the etiology or the cause of the metabolic acidosis, is looking at our anion gap. So we did say that our sodium level is our main cation in the extracellular fluid compartment. If we subtract that from our main anions, our chloride and our bicarbonate levels, we will get the difference then between the positively charged electrons and the negatively charged electrons, or electrolytes, excuse me. The normal value here is 12. If we have an anion gap that is greater than 12, we can say that the etiology of the metabolic acidosis is from an increase in these fixed acids. If the anion gap is low, then we can say it's due to a loss of bicarbonate. Now, that is a little less common to just have your body lose bicarbonate, but one common clinical example is that is if your patient is getting a significant amount of Lasix to get rid of that extra edema in the interstitial spaces, then that can drop the bicarbonate level. Our kidneys work creating urine and excreting substances as necessary through first filtration, and that's where the glomerular capillaries are permeable to water and electrolytes. Therefore, water, sodium, glucose, amino acids, and a variety of electrolytes can be reabsorbed as needed. And when we say reabsorbed, we mean those capillaries become permeable and allow for the capillaries to hold on to or keep those substances and go back into our circulating blood volume. Commonly, hydrogen ions and potassium ions are secreted from the blood to the urine, and that will help maintain the neutrality needed. So sodium is the main cation of the extracellular fluid, and it controls osmolarity. Potassium is the main cation of the intracellular fluid, and it controls the polarity for special nerve and muscle function. If we have a high potassium hyperkalemia, it will be secreted into the urine. If we have a low potassium, what will happen is hydrogen ions will have to go into the intracellular compartment to try to maintain that electroneutrality, and a metabolic alkalosis will happen. If we have a high amount of potassium, so we would call that hyperkalemia, once again, hydrogen ions would have to exchange, and they would then be in the blood, and more hydrogen ion concentration would cause a metabolic acidosis. So when your patient has an acidic extracellular fluid status, your kidneys will secrete more hydrogen ions into the urine. And if we have an alkalinic extracellular fluid status, your kidneys will secrete bicarbonate into the urine. Finally, the last acid-base disturbance we'll look at is metabolic alkalosis, and that's when the pH is greater than 7.45, the PaCO2 is within normal limits, and the bicarbonate level is increased above 26. There will be respiratory compensation if the pH is within normal limits and the PaCO2 is greater than 45, and we can call that a chronic sample. There's only partial compensation if the PaCO2 is raised greater than 45, but the pH is not back to within the normal range. So we're going to look at a couple of case studies. Before a cardiac arrest, a 67-year-old man with an acute myocardial infarction, a heart attack, had normal levels of serum electrolytes. The level of sodium was 140 millimoles per liter, potassium of 4, chloride of 103, and a bicarbonate level of 25. All those values are within normal limits. While he was anuric, or he quit urinating after the cardiac arrest, his laboratory test showed a sodium level of 140, a potassium of 5, a chloride level of 62, and a bicarbonate level dropped to 5. The arterial pH was 710, and the PaCO2 was 16 millimeters per mercury. The lactate level was 60, and the anion gap was 73. So let's look at those different values. So the patient was, within normal limits, and then he went into cardiac arrest. Cardiac arrest is where your heart stops, and therefore oxygen and carbon dioxide, as well as those electrolytes, are not transported in the body. Therefore, we have a pH value of 710, which is a severe acidosis. We have a PaCO2 of 16, which would lead to a respiratory alkalosis. And we have a bicarbonate level of 5 millimoles per liter, very low, and that contributes to a major acidosis. So if we look at the pH or the arterial blood gas interpretation, we can see that this patient has a partially compensated metabolic acidosis. We look at the anion gap level, and the difference should only be 12, but because this patient's chloride level and bicarbonate, so the anions are very low in the blood, the anion gap is 73. When we say 73, that's well above 12. So that means this person has a large amount of fixed acid building up in his body. Also, the lactate level should only be approximately 2 millimoles per liter, and due to the cardiac arrest, his lactate level is 60. So that is stating that in this person's case, lactate overproduction due to hypoxic tissues really produced a lot of lactic acid, as well as increased that lactate level just due to the overall anaerobic environment. Hydrogen ions were overproduced, and bicarbonate ions were reduced to achieve neutrality. The chloride moved into the cells to neutralize the bicarbonate and the lactate levels. So this is actually a common case that you guys may see in the hospital as you deal with intensive care unit patients that do experience cardiac arrest and hypoxic environments. Here's another case. An 80-year-old man with congestive heart failure received furosemide, which is a Lasix or a diuretic, until all peripheral edema disappeared. Laboratory tests revealed a sodium level of 130, potassium of 2.5, chloride of 80, and bicarbonate of 40. The arterial pH was 750. The PaCO2 was 53. So if we look at this arterial blood gas, 750, 53, and a bicarb of 40, we see a partially compensated metabolic alkalosis. So if we look at this patient's issue, he was getting a significant amount of diuretics. Therefore, chloride was lost in the urine due to diuretics. Bicarbonate was then reabsorbed to gain neutrality, and therefore the metabolic alkalosis is the end result. And he does have partial compensation from the respiratory system, but not enough to make this a fully compensated. Okay, we're going to look at and review some arterial blood gas samples here. So 735, 62, 50, and 30. This patient has a chronic respiratory acidosis with full metabolic compensation. As you can see my picture here, he is one that is already on oxygen. So this patient is a chronic patient. This patient probably lives in these ranges. So if the patient is not in any distress, this is how the patient lives, and you don't need to treat this patient. The patient next to him is sweating and hyperventilating because he's nervous. So this patient has 751, 30, 60, and 24. This patient has an acute respiratory alkalosis, so no compensation, and he does have mild hypoxemia.
To the front office in building A. That's the building where your class is. If you could please come to the front office.
Excuse that interruption. Okay, two other samples I want you guys to work on. 737, 30, 54, -5, and 16. So if we look at this, 737 is within normal limits. PaCO2 of 30 is low, so that would contribute to an alkalosis. PaO2 of 54, and the bicarbonate is 16. So that would also contribute to an acidosis. Then we would look and say, well, 737 is more acidic than alkalotic due to the fact that it's less than 7.40, we could say that this person has a fully compensated metabolic acidosis. Now let's look at the next one, 7.26, 51, 49, and 24. This patient with 726 is acidotic. A PaCO2 of 51 is also acidotic. A PaO2 of 49 is moderate hypoxemia. So this patient has acute respiratory acidosis with moderate hypoxemia. And I do want to say that the previous example, the patient's PaO2 of 54 is also moderate hypoxemia. Okay, 710, 14 and 4. This patient has a metabolic acidosis with partial respiratory compensation. The electrolytes then are 128, 90. So if we say 128 minus 94, we're going to look at that anion gap. And we said before that the anion gap should be 12 as normal. So 128 minus 94 is 34. So we know that that's greater than 12. So the etiology or cause of this patient's metabolic acidosis is from an increase in fixed acids in the blood. So that's either lactic, keto, uric, or phosphoric acid. Okay, let's see here. So one we just did. Okay, 23-year-old asthmatic woman presents in the ED with moderate respiratory distress. Her initial ABG is 756, 20, 20, and 85. So that is a partially compensated respiratory alkalosis with normal oxygenation. A 72-year-old male presents in the emergency room with acute renal failure. ABG 7.20, PaCO2 of 60, and a bicarb of 22, and a PaO2 of 60. This patient has an acute respiratory acidosis with mild hypoxemia. A 59-year-old male presents in the ER with vomiting over the past few days. The ABG is 755, 47, 34, and 85. So this patient has a partially compensated metabolic alkalosis with normal oxygenation. A 15-year-old female status post motor vehicle accident was placed on mechanical ventilation. ABG 753, 15, 16, and 75. This patient has a partially compensated respiratory alkalosis with mild hypoxemia. The nurse hands you an arterial blood gas with a large air bubble in the syringe. The arterial blood gas comes back with a pH of 750, a PaCO2 of 60, and a bicarb of 22, and a PaO2 of 99. You would then say, wow, I must need to recalibrate my arterial blood gas machine because this can't happen. In this sample, the pH is 750 or alkalotic, whereas the CO2 and the bicarbonate, so the respiratory and the bicarbonate system, is leading to an acidosis. So there's no way, if you did Henderson-Hasselbalch, you could get a pH of 750 with these acidotic samples. Just redraw the sample and make sure that it's calibrated. It's that large air bubble that is adding room air into that sample. Here we go. A 29-year-old female is found down in a park by some bystanders. The medics are called and upon arrival find her with an SpO2 of 88% on room air with pinpoint pupils on exam. She is brought into the ER where a room air arterial blood gas is performed. pH 725, PaCO2 of 60, bicarbonate of 26, and a PaO2 of 65. So she has an acute respiratory acidosis with mild hypoxemia. Her electrolytes 137, 127 are within normal limits. So the pH indicates she's acidotic, CO2 is high, and the bicarb is normal. So we do say that the gas is an acute respiratory acidosis. There's not compensation yet, and the anion gap is just fine, and it wouldn't tell you respiratory-wise, the anion gap is reserved for metabolic acidosis. Okay, so PaO2 is 65 on room air, and this happened at sea level. What do you think is for the reason for her hypoxemia? I would explain her hypoxemia happening from that high PaCO2 level, so she is hypoventilating. Next case, a 60-year-old male with ALS is brought into the clinic by his family or concerned that he is more somnolent than normal. On history, they report that he has been having problems with morning headaches when he wakes up. His pH is 737, PaCO2 is 57, his bicarb is 32, and his PaO2 is 70. So this gentleman has a chronic or a fully compensated respiratory acidosis. And most likely, he also has mild hypoxemia. So most likely with this patient, he's hypoventilating at night. And so therefore his CO2 levels and oxygen levels are going down. And that's the problem. That's what's causing the headaches and the somnolence. Okay, a 47-year-old female with a history of inhalant abuse presents to the ER complaining of dyspnea. She has an SpO2 of 99% on room air and is obviously tachypnic on exam with what appears to be Kussmaul's respirations. Her pH is 6.95, her PaCO2 is 9, her bicarbonate level is 2, and her PaO2 is 128. So this patient has a severe, partially compensated metabolic acidosis. Her sodium level is 130, her chloride level is 98, and her bicarbonate level is 2. So the pH indicates acidosis. The PaCO2 is low and the bicarbonate is low. So this system implies that the metabolic system is the primary disturbance. The anion gap is the difference between sodium of 130 and chloride and bicarbonate that is 100. Oh, excuse me for that. And so we can say that the anion gap is 30. Therefore, she is having an increase in her fixed acids, and that is what is contributing to her metabolic acidosis. Does the patient have a shunt or low VQ ratio? Does there seem to be any lung parenchymal issues? Why is the PaO2 elevated even though the patient is on room air at sea level? So the clinical explanation from this is the reason her PaO2 is so high is because you can tell she's extremely hyperventilating. And you can tell that because of her PaCO2 level at 9. So I wouldn't say that she does have any shunting or abnormal VQ ratio or lung parenchymal issues. It's just related to ventilation. She's hyperventilating. Let's go on to our next one. A 68-year-old male with a history of severe COPD with an FEV1 level of 25% predicted and chronic air trapping presents to the ER complaining of worsening dyspnea and an increase in the frequency and purulence of his sputum production over the past 2 days. His pH is 725, his PaCO2 is 68, bicarbonate of 31, and PaO2 of 48 with a SATS of 78. This person has a partially compensated respiratory acidosis with moderate hypoxemia. So a PaO2 is 48 torr on room air, and this happened at sea level. What is his AA gradient? So if we're looking at this gentleman at room air at sea level, we really could assume then, doing the equation, and we'll use the AA gradient equation. So if he is at sea level, then we can say 760 minus the water vapor pressure of 47. And if he's on room air, that's multiply that by 21% or times 0.21, we get 149. And then minus his PaCO2 level. Now that's high here, it's 68. So minus 68 times 1.25, all in parentheses, we get 64. And his PaO2 is only 48. So that's a difference in approximately 16. So it looks like, once again, that this isn't related as much to a diffusion defect as much as the fact that this patient, once again, is hypoventilating because his CO2 is 68. Remember, no matter what the labs show, don't forget to look at your patient. Thank you for joining me.